I hope the presenters are present for the free paper 410. Yeah. Aphakia conquered comparison of technique and outcome between two sutureless SFIOL techniques. I think we will start, sir. Start the session. You want to introduce yourself or something?
Hello, I am Dr. Tamojit Chatterjee, Assistant Professor, Department of Ophthalmology, Raiganj Government Medical College. Okay.
Myself, Dr. Hemlata, retina specialist from AIO, Bangalore Medical College.
I am Dr. Santosh Mahapatra, Chief Medical Officer, JP Rotary Eye Hospital, Cuttack, Odisha.
I told you, first paper.
I'd like to invite Dr. Chintan Desai. Is he here?
Free paper 1009.
He- Not there. Okay. Next one, Professor Abdes Ali. Ali. Okay. Suprachoroidal triamcinolone in epiretinal surgery, a safety and efficacy study.
Good afternoon, judges and colleagues. The topic of my presentation is suprachoroidal triamcinolone after ERM surgery, a safety and efficacy study. No financial disclosures. So ERM, as we know, is a fibrocellular proliferation in the macular area, and it leads to clinical symptoms because of anatomical and physiological changes in the macula. The prevalence is 5 to 12%, out of which 1/5 are bilateral, and the standard of care is pars-plana vitrectomy with ERM peeling. Of late, various adjuvant treatment options are being tried because the macular edema takes some time to subside. So earlier, there are studies of using intravitreal triamcinolone, but the side effects of increased IOP are quite significant, and later on, steroid implants like Ozurdex are also tried. But they all have add on to the cost of the surgery and have significant side effects. So this suprachoroidal triamcinolone is new to the therapeutic armamentarium, and recent studies have shown that it leads to improved efficacy and lesser side effects. Now it has been used in various trials in retinal vein occlusion, pseudophakic CME, and diabetic macular edema, and even uveitis. Triamcinolone, as we know, is commercially available, but it requires a microneedle or catheter for injection, which is not commonly available commercially out of the trials. So we innovated and modified a 26-gauge needle along with sleeve of a 22-gauge cannula for safe and cost-effective delivery of suprachoroidal triamcinolone. So was the idea of this study to determine the efficacy and safety of triamcinolone suprachoroidal for regression of macular edema and improvement in visual acuity. So this was a prospective non-randomized study which included 20 patients with idiopathic ERM, and all patients underwent pars-plana vitrectomy with ERM peeling, who had visual acuity worse than 612 and evidence of ERM on OCT. Patients with glaucoma, other retinal pathology, and follow-up less than 6 months were excluded. So among these 20 patients, 8 eyes did not receive suprachoroidal triamcinolone, and 12 eyes in the suprachoroidal triamcinolone, 12 eyes received suprachoroidal triamcinolone, which was 4 mg in 0.1 ml. This is how the needle was made, that you just dock it from the other end of a IV cannula outer tube, and then keep the tip exposed, and then this injection can be given. After vitrectomy, sometimes if you are at 25 or 30 intraocular pressure, then momentarily you can increase it to 60 so that the injection is easier. This is of late, this is the intra-op OCT picture of one procedure being done, wherein you can see the needle shadow and triamcinolone in the suprachoroidal space. The outcome variables were central retinal thickness, vision, and intraocular pressure measured at pre-decided time points. And so all these patients had a mean follow-up of 6 months, and most of them were pseudophakic. This is one of pre and post images of a patient with thick ERM, disorganized retinal architecture, but after the surgery at 6 months, this is the outcome. If you look at the vision changes, there was significant improvement in visual acuity at 3 and 6 months, which was statistically significant. And looking at CRT changes, the changes started earlier than improvement in the visual acuity at 1, 3, and 6 month follow-up. This is the pictorial representation of reduction in CMT. So CMT started reducing from 1 month onwards, whereas vision was significantly different at 3 months. If you look at the safety, redness, transient pain, and conjunctival hemorrhage were most common. There were no significant complications like endophthalmitis. And one concern always is there regarding intraocular pressure with the use of steroids. So we quite elaborately studied the intraocular pressure changes, and at 3 and 6 months it was near to the baseline. So to conclude, suprachoroidal triamcinolone led to an accelerated improvement in vision and reduction in CRT at 1, 3, and 6 months after surgery. And this offers a valuable alternative to expensive steroid implants. This technique is now being used for various indications across the world, and it led to significant improvement in these patients of epiretinal membrane after surgery. Thank you.
Thank you. I have 1 or 2 questions for you, sir. How do you quantify the improvement in vision is due to suprachoroidal triamcinolone? Because you are combining epiretinal membrane peeling along with triamcinolone.
Sir, in this actually, though it was non-randomized, but we had 8 patients who did not receive the suprachoroidal triamcinolone, and 12 patients had received suprachoroidal triamcinolone. So then we compared these 2 groups. Then we found that there was significant difference in reduction in macular edema after 1 month onwards. Till 1 month there was no significant improvement, but after 1 month the reduction in macular edema was much more in the triamcinolone group. Same goes for the vision, though at 1 month, till 1 month there was no significant improvement in vision, but 3 and 6 months they significantly had better vision than the group which had received, which had not received suprachoroidal triamcinolone. So that was the only factor which was different.
Do you use preservative free or?
Yes, sir. This is same Orocort which we get preservative free, which is for intraocular use. That only we use.
Then you could have used a smaller gauge needle, because they have the particle size is much less instead of a 26 gauge needle.
Sir, with 26 gauge needle, I find that the flow and everything is absolutely fine, and I have not yet encountered any complications. Plus now with AIOC guided injections, we actually can localize where the drug is going. Though your idea is very valid that even smaller needles would be helpful.
Sir, my query is, I mean, the etiology for the ERM, all are idiopathic or secondary ERM?
They are all idiopathic
All
ERM,
are
ma'am,
idiopathic.
where we could not find a reason.
Is there any chance of occurring of any suprachoroidal hemorrhage during the injection?
Sir, out of my limited experience, maybe of 1.5 to 2 years now hundreds of these suprachoroidal injections have been given. I have not yet encountered, though theoretically definitely there is a possibility, sir. So we should be careful. Thank you.
Thank you, sir.
Now the next figure, interpret by Professor Dr. Pradeep Kumar.
So good afternoon, ladies and gentlemen. I'll be speaking on something which is actually opposite to what is being driven by the market about the importance of brolucizumab. Though I speak a lot about its efficacy in neovascular AMD and diabetic retinopathy, today I am going to speak about the non-superiority of brolucizumab when it comes to myopic CNVM. So we all know these establishes usage of brolucizumab. These indications have been validated. For novel applications like in myopic CNVM, it's extremely important to take an informed consent, and you should have a ethics committee clearance. Myopic CNVMs behave differently because they are usually type 2, they are above the RP. There is a debate between 3 loading dosage followed by PRN or going to PRN straight away. We went with the PRN codes in our study. The results, they have been titrated against various biomarkers like axial length, but nothing has till date proven that which particular biomarker will give us the prognosis of a particular myopic CNVM. So this was our trial where we wanted to compare the 2 drugs head on. It was a prospective observational study. because why we do not label it as interventional, because for a RCT trial, a much larger sample size was required. So this was not a non-inferiority trial, but this was an observational study of limited number of patients. So we went ahead with standard parameters, took 4 weekly readings for 52 weeks. So that's a 1-year follow-up for both subset of patient. I'll come to my patient. This was a 32-year-old lady presented with best-corrected visual acuity of 6.9, was complaining of metamorphopsia, post first brolucizumab, had drying of the macula, by 12 weeks, showed recurrence again, received second dose, and following that patient remained at 6.9 throughout the observation period. So this was a happy story. Now coming to another case where the right eye best corrected visual acuity was 660. This patient had earlier received ranibizumab and aflibercept. This time was randomized to the brolucizumab group, was non-responsive to the two drugs. Came to best corrected visual acuity of 6. The right eye required 4 injections in 12 weeks. And this patient very gradually improved and at 18 weeks achieved 618. Now another case where the brolucizumab was started de novo. This patient from 636 moved to 618 in 4 months and remained stable thereafter. Another case where we see that right eye is stable while left eye received 6 injections in 1 year and moved from 4/60 to 6/36. So by now you can see the trend of variable response with brolucizumab. It is not a panacea as has been documented with other diseases. This case required 3 injections just to maintain from 618 to 612 over a year. The 6th case, 5 injections over 9 months, and another case, 2 brolucizumab in 1 year moving from 660 to 612. So we had 10 patients in brolucizumab group, 9 patients in ranibizumab group. When we looked at the change in best corrected visual acuity, in brolucizumab group we moved from 0.62 to 0.37 with a change of 0.25 logMA units. While in ranibizumab group we moved from 0.73 to 0.46, 0.27 logMAR units. So there is not too much best corrected visual acuity change difference between the two subgroups. Same was the story with the central macular thickness. Now the key question why we did this study was to study whether there was a prolongation of inter-injection interval, which is so well talked about. We had to give 47 injections in the brolucizumab subgroup while 46 injections in the ranibizumab subgroup. So here comes the conclusion of our study that though brolucizumab can be used, it works just as well as ranibizumab. It does not act better. You cannot achieve longer inter-injection intervals, especially in cases of myopic CNVM. So the unpredictability of myopic CNVM remains. So this is the conclusion, and though this study gave out a negative outcome, it is extremely important in our scenario when in a country like ours, we are dealing with increasing healthcare costs and budget remains an extremely vital issue when treating patients. So we do not feel that brolucizumab should be indicated for myopic CNVM. Thank you so much.
Thank
Very
you.
good presentation, sir. Like in your case in series, did you had any reaction like as mentioned?
No, ma'am. Here we gave very few injections. We have a larger data of about 1,770 injections till date at our center. We have had 4 IOIs, but none in this series of myopic CNVM. No IOIs in this series. But yes, I like to bring out this point that once you are giving brolucizumab, one should carefully monitor the patient. IOIs do occur, and when they occur, you will require steroids to control the inflammation.
What is the average number of injections in each group?
In each group, 4.6.
And what was the criteria to give the injections at
Okay.
what interval?
Yeah, so the retreatment criteria for the shortage of time, I did not come out to that, was drop in visual acuity by 1 line, that is 0.10. If we saw any appearance of new SRF or IRF on OCT, and if the patient complained of increasing metamorphopsia. This was a subjective feature, but it is very vital that in most cases of myopic CNVM, when the disease activity recurs, the changes in OCT are picked up later rather than the symptoms of the patient. So it is mostly the symptoms of the patient which determine whether re-injection will be done or not.
Did you see any difference in the repeatability of between brolucizumab and?
Exactly, that was the point of doing this study, sir. We were expecting a longer inter-injection interval, but it did not occur. That is why we are recommending that one should not say that brolucizumab gives a longer injection interval in myopic CNV.
what is the usual interval?
Oh, the usual interval in neovascular AMD
your
has
case.
been 14 weeks. In
No,
diabetic
in
macular
your
edema,
case,
yeah, I am talking about our cases. In neovascular AMD, we have had 14-week inter-injection interval. In diabetic macular edema, we have had a 9-week inter-injection interval. So yes, this gives a fairly long inter-injection
and
interval.
in myopic CNV?
In myopic, no, sir. In myopic, you have to repeat just as well as ranibizumab.
You give the ranibizumab, that is the biosimilar or ordinary?
Sir, just for the sake of making comparison for the study to be acceptable for publication, we use eccentrics. We use both eccentrics as well as razumab at our center. I do not find any difference between the two drugs, but since it has to be published, so we used eccentrics along.
Thank you.
Thank you.
Thank you, sir.
Okay. The next paper, amniotic membrane plug to promote the retinal breaks, repair and recurrent macular hole closure. Speaker is present?
Not presented.
Not present.
Next.
So next one, perfluorooctane as short-term tamponade
Pediatric RP.
in pediatric rhegmatogenous retinal detachment with PVR. Presenting author is Nawaz Sheikh. Dr.
Good afternoon, everyone. I'm Dr. Nawazish, and I'll be presenting our outcomes of perfluorooctane as a short-term tamponade in pediatric rhegmatogenous retinal detachment with proliferative vitreoretinopathy. So as we know, pediatric rhegmatogenous retinal detachments, the success rate is as low as 50% because despite complex vitreoretinal interventions and heroic maneuvers that we do, keeping this in mind, our purpose was to evaluate our experience and outcomes of short-term tamponade using perfluorooctane in pediatric rhegmatogenous retinal detachments with proliferative vitreoretinopathy. So it was a retrospective analysis of children less than 12 years of age who underwent 25-gauge pars plana vitrectomy for pediatric RRD with PVR using perfluorooctane as a short-term intraocular tamponade by a single surgeon. Only those patients were included who had at least 3 months of follow-up after the removal of the perfluorooctane, and primary and secondary outcomes were assessed. So 9 eyes of 9 patients were included. The mean age of the patients was 8.66 years. The mean duration of tamponade of perfluorooctane was 10.44 days with a range of 7 to 12 days. Coming to the primary outcomes, at the end of 3 months, 7 out of 9 eyes had reattachment after primary surgery, whereas the 2 eyes that had a redetachment underwent an additional surgery, of which only 1 succeeded, making it ultimately only 8 out of 9 eyes having reattachment at 3 months. That is roughly 90%. The secondary outcomes was there was an improvement in the visual acuity and no sight-threatening complications of perfluorooctane in the form of corneal opacification or subretinal PFCL was seen in any of the patients. The first image is the intraoperative screenshot at the end of surgery with perfluorooctane fill. The second image is the intraoperative screenshot during the second surgery where the perfluorooctane was exchanged with silicone oil. We preferred silicone oil as we were expecting PVR and redetachment in these patients. They had PVR grade C onwards in these cases, so we went ahead and exchanged it with silicone oil. The image 3 represents the intraoperative screenshot of peripheral vasculitis seen during the time of removal of the perfluorooctane. Thankfully, the patient responded to oral steroids. These are some of the images, ultra-wide field fundus images of some of the patients that had oil in situ. So as we say that pediatric RRDs usually present late, they involve the macula, there is a high propensity for PVR, and these children seldom take the positioning that is required following oil insertion. But there are properties of PFO such as optical clarity, high specific gravity, low viscosity, and immiscibility, which makes it a good tamponading agent, especially for inferior RRDs. But it is not free of complications. It can cause mechanical toxicity and intraocular inflammation, making it unsuitable for long-term use. In children, it helps us by allowing us an extended apposition of retinal tears to the RPE for strong chorioretinal adhesions to form. It's a better agent in patients having an inferior RD or breaks, as well as it shifts the cellular mediators of cellular proliferation away from the retinal surface as it's in close apposition to the retina. In case of a silicone oil, there is a small layer of aqueous fluid still present between the inferior retina and the oil bubble, where the cellular mediators of cellular proliferation may accumulate and cause PVR, causing a redetachment. But this procedure in children requires 2 stages. So general anesthesia has to be given to these children twice, which may be a problem in syndromic children. The 2 eyes that failed in our study had recurrent PVR, and they did not have an encircling element used in the primary surgery. However, a success rate of 78% at the end of primary surgery is very encouraging, especially in pediatric RDs. At the time of submission of this abstract, 5 out of 9 eyes had undergone SOR, following which another 2 eyes underwent SOR. So again, a 78% of success rate after SOR is a very encouraging result in pediatric patients. The limitations of our study was a small sample size. We did not have a long-term follow-up of these children, as well as no other studies, no other tests such as an OCT or an ERG were done to look for toxicity other than visual acuity in these children. The conclusion is that the rate of successful retinal reattachment was roughly 90% at the end of 3 months of PFO removal. PFO as a short-term tamponade is considered to be safe and effective in pediatric retinal detachments and PVR changes. Thank you.
Thank you. But there is no comparative arm, I think.
No, sir, there's no comparative answer.
So it would have been better if you were compared. The
Yes,
number
sir.
is small. Like eyes with silicone oil in
Yes,
one
sir.
arm, and eyes with
Yes, sir.
PFO in the
So
other.
we only attempted PFO silicone oil in patients in which we were anticipating a redetachment. Any patient who had presented to us with a giant retinal tear with PVR grade C onwards. So comparison between the two would have been difficult in that case.
And that too, the grades of PVR also, I
Yes,
think,
sir.
are different.
Yes, sir.
Yeah,
Okay,
my
thank you.
query was out of 9, 5 belt buckle encirclage was not
Yes.
used, I believe, no?
Ma'am, 5 encirclage was used.
Used.
4 it was not used. Out of those 4, 2 redetached. In the second surgery, both had an encirclage put in
You
place, but one
supplemented.
failed. Yes.
So there are multiple variables. So
Yes.
comparativity is less.
Yes, sir.
Thank you.
Thank you so much, sir.
The next speaker is clinical profile and surgical outcome of optic disc pit maculopathy. Dr. Mohammed Nikhil KS is there. Whereas we'll move on to the next free paper, clinical features, genotype and phenotype correlation in cone dystrophies of Indian coherent. Dr. Priyanka Gandhi.
Good afternoon, everyone. Thank you, AIOS, for this opportunity. Cone dystrophy is an inherited retinal dystrophy characterized by loss or dysfunction of cone cells. Its incidence varies in 30,000 patients. Inheritance pattern is varied. It can be dominant, recessive, sporadic, or X-linked. It can be progressive or stationary in nature, and it has varied clinical features. Our goal was to study phenotypic and genotypic variations in these patients in an Indian cohort. And the objectives were to correlate phenotypic and genotypic variations in these patients and to contribute to the existing database of retinal dystrophies. It was a retrospective study. We looked at visual acuity, presenting complaints, pedigree charting, clinical examination, OCT, fundus autofluorescence, ERG, and genetic tests. Our study population had 61 patients, out of which 75% were males and 25% were females, which the age varied from 3 years to 58 years of age, and 43% of these patients had family history of consanguinity. Of the presenting complaints, diminution of vision was the commonest among our study population, followed by photophobia, nystagmus, and some of them were asymptomatic and had night blindness complaint. And the visual acuity was 42% of the patients. It was ranging from 624 to 648. Color vision was grossly abnormal in 30% of these cases, and rest had variable results. For an example, a 22-year-old male came to us with a diminution of vision in both the eyes since childhood. The vision was 636 in both the eyes and had history of photophobia. On examination, fundus appeared normal in both the eyes. Autofluorescence showed subtle changes at the macula. And on OCT, we could see the cavitation here, showing the outer retinal layer disruptions. And on ERG, we saw that the Dark adapted showed reduced response, while the light adapted responses were undetectable. The second case was of 6-year-old male who also came with complaint of diminution of vision in both the eyes and had vision in right eye 648 and left eye 636. Fundus appearance on clinical examination was normal. Also, the fundus autofluorescence, as you can see here, which appeared near normal. On OCT, we could see that there was outer retinal layer disruption. On ERG, the dark adapted responses were reduced and the light adapted responses were unrecordable. The fundus findings in these patients, the commonest was bullseye maculopathy, followed by the RP changes at the macula and arterial attenuation, and the rest of them showed disc pallor pigmentary changes was normal in some patients. On OCT, we had outer retinal layer disruption was seen in 43% of these cases in the form of foveal atrophy, cavitation, ileum disruption, or was near normal. ERG, the photopic responses were undetectable or severely reduced with or without reduced photopic responses in 67% of these cases. Only 4 patients underwent genetic testing from our study population, which revealed the gene mutations in CNG A3, CNG B3, C8, ORF37, and ATF6. The key points here are that the cone dystrophy can be misdiagnosed, can be assumed as malingering in presence of normal fundus appearance. Some forms of these cases may be falsely considered as a progressive blinding disorder. So understanding of the disease helps in prognosticating and counseling these patients. So what we knew before the study were the inheritance patterns, clinical phenotypes, gene mutations, and syndromic associations, and the overlapping features with other retinal dystrophies of these cases. This study adds that an improved Indian database of cone dystrophy cases, phenotypic variations and genetic correlations, and highlights lack of awareness about the disease and genetic testing. So moving ahead, the awareness should be created, genetic counseling should be done, genetic tests and gene therapy. Thank you.
Thank you. What is the prevalence of this disease in Indian population, cone dystrophy?
Sir, it is about 10 to 15% in India.
How much your study populations?
61, sir. 61 patients.
You mean 10 to 15% of the population has cone dystrophy?
Yes, sir.
How does it change in the management of the disease? Your study?
Sir, because the consanguineous marriages are so common in India, it is very important to create awareness so that the disease can be, before we detect it, it can be also halted the progression of the disease, also the chances of getting the next generation, we can lessen it. And also, if we detect them, we may not be able to do it right away, but in future, so with gene therapy and gene testing, definitely there will be.
It's a preventive management.
So right now we are
Change
in the.
in management pattern? No.
So right now we are just monitoring them, and in future.
Thank you.
Thank you.
The next speaker, that is a paper back to the back, white use of monochrome filter and 3D visualization for safer ILM peel. Chief author Dr. Srinivas Joshi, presenting author Dr. Sneha Kher.
We're going this. Next page, yeah, from here. This one, sir.
Good afternoon, everyone. Today I am presenting about back-to-back in black and white use of monochrome filter and 3D visualization system for safer ILM peeling. Introduction. 3D visualization system is truly a game changer. It is an ergonomic improvement in terms of comfort for operating surgeon as well as for the patient. Color filters help in better visualization. PDR surgeries forms the majority of VR surgeries. Membrane peeling is frequent step in every surgery. Idiopathic macular hole cases requires ILM peeling invariably. The investigator of this study has vast experience of operating on analog microscope as well as 3D system. In this study, we evaluate the ease of membrane peeling using 3D visualization system and its advantages. In this video, we can see the ILM is pinched and lift, and we are using a monochrome filter which is helping in visualization, and it minimizes the membrane shedding due to multiple grasping attempts which is made, and This causes lesser amount of trauma to the retina in the process of membrane peeling. So these are the results. The mean pre-op visual acuity in the group A was 1.326 logmar, and in group B was 1.036 logmar. Post-op visual acuity in group A was 0.904 logmar, and in group B was 0.706 logmar. Time for ILMP in group A was 10.8 minutes, and in group B is 8.4 minutes. Amount of BBG dye which was used in group A was 0.26 ml, and in group B is 0.18 ml. Number of pinches made to lift the first ILM flap in the group A is 2.8, and in group B is 2. Discussion on Pellecisio et al. Reported that the use of black and white filters facilitate the visualization of ILMP, being the most useful after the flap has been lifted in patients with atrophy of the RPE due to better visualization of membranes and improved depth of focus compared to the conventional systems. In the study by Mello AGR, they used the higher values of hue, which improved the visualization of ERM and internal limiting membrane. A study by Zindal et al. Have reported the toxic effects of brilliant green in retina. Park SJ have reported the percentage of dye used during the surgery have been decreased from 0.075 to 0.023% by using color filters. There have been various studies that claim 3D visualization system did not affect the surgical times, and some studies report that it took them longer on the 3D system. Digitally assisted vitrectomy systems are a great aid in vitrectomy for a surgeon, and it provides better depth of field, high quality visualization at the lower levels of illumination, as reported by many studies. In conclusion, the mean visual acuity is comparable between both the groups A and B, and hence both analog and 3D vitrectomy system had statistically significant improvement in visual acuity gain post-operatively. There is a reduction in amount of dye used, decrease in number of pinchers to lift the first ILM flap, and lesser time required for ILMP using monochrome filter in 3D visualization system. Monochrome filter with 3D visualization system provides us with a safer and efficient alternative for ILM peeling. So these are my references.
Okay, good presentation. Was there any criteria of size of macular hole also kept, like when you comparison between the two groups?
It was all the cases what we used was both for PDR surgery we have done the ILM peeling as well as the macular hole cases. In our cases, it was all less than 400 microns.
Okay, and also you mentioned about the criteria of time, no? How you really calculated, like?
We had a questionnaire, ma'am. So we noted down the time used for each and every surgeries. The time started from the first ILM pinch, and by the time we completed the ILM peeling, we calculated the time in between.
Was the surgeon aware that the time is being noted?
Sorry,
Was
sir?
the surgeon was aware that the
Yes,
time
sir.
is being noted?
Yes, sir.
Okay.
You use only the pinch and peel technique or any other finish loop or anything?
In our study, we used only pinch and peel technique.
Nice, thank you.
Okay, thank you.
The next topic is triamcinolone injections. Why 30 gauge needle may not work? Dr. Ajay Arora, sir.
Thank you. So this is a very basic presentation of a topic which, is the first time it's ever being presented. So we all know about various triamcinolones available in the market. So commonly triamcinolone which we used to use was Tricot by Cadila Pharmaceuticals. This was most commonly used preparation before the preservative-free triamcinolone became available, and usually a 26 gauge needle is used to inject Tricot. It is difficult to inject with a 30 gauge needle. The question is why? So this was only one reference to this. This was presented in RVO, where they looked at the mean flow rate between 27 gauge, 30 gauge and 32 gauge between the preserved triamcinolone and preservative-free triamcinolone, and they found out that it's better to avoid smaller gauge needle because of the possibility of clogging, presumably caused by obstructive accumulation of triamcinolone aggregates. So PFT has been shown to form aggregates of smaller size than triamcinolone with the preservative. So I had to find out whether this is really true. So we did this study at the IIT Delhi with the scanning electron microscopy lab with the Carl Zeiss EVO18 SCM at IIT Delhi, and we wanted to see if the tricot can be injected. So we studied triamcinolone, tricot 40, which is preservative, and then preservative-free of Oracort, which is made by Oralab, Corti, which is made by Kleisch Healthcare, and we also got a sample of Zuprata, which was by Clearside Biomedical, which you may have heard of the Clearside Biomedical study. The SEM sample was prepared, was drop casted with a micropipette, dried at 40 degrees centigrade, gold sputtered, and this was then placed in a vacuum chamber of SEM, and then they were studied. So the results, triamcinolone, so this is an SEM picture of tricot particle. You can see here, so it is believed by people that tricot may have larger particles, therefore they do not go through a 30 gauge needle, but actually they have the smallest of all particles, which was a revelation to me. So the particle size is 1 to 4 microns, but most important is most of the particles are uniform sized. So what is the relevance of uniform size? I'll just reveal. Then we looked at Oracort. The particle size here are some are larger, some are smaller, which is about 1 to 8 micron size. But what is important is there's a massive variability of the particle size in Oracort, and this is at 5000 magnification. This is Corti, beautiful picture of triamcinolone. The particle size was 1 to 12 microns. Again, there was a significant variability in particle size, and that was very, very important. So this is Zuprata, and when we heard about Clearside, they said that they have a special triamcinolone, but actually similar to Oracort is 1 to 8 microns, and this is all the pictures put together. So in conclusion, it is the small uniformly sized particles of tricot. They stack up and clog the 30 gauge needle because they go against each other and form a clog. The variable size particles of the preservative-free triamcinolone do not clog it because they cannot clog it. They cannot stack up behind each other. The Oracort molecule is quite similar to Zuprata of Clearside. Why is this concept important? Because this concept of differential particle size variability will help us in deciding that they can be injected through a small gauge needle, especially the suprachoroidal injections, by increasing the types of agents which will be available for intravitreal and suprachoroidal space as well as subretinally. So this concept may help in deciding about drug formulation. Thank you.
Thank you, sir. We are before time. So questions?
Very nice, excellent concept, sir. We really appreciated that.
In fact, I would not reveal, but there's a company which is doing some study on dry AMD, and so I have made a suprachoroidal device, and they want to try that. It's a US-based company which might be using similar concept for suprachoroidal injection and dry AMD. I can't reveal further, but
that is all right, sir.
Yes.
Thank you.
Thank you very much.
Okay, the next presentation is OCT findings in large full thickness macular hole after ILM peeling with multi-layered inverted flap technique. Presenting author Dr. Binoy Patil.
So good afternoon everyone. So I shall be presenting the OCT findings in large full thickness macular holes after we have done ILM peeling with multi-layered inverted flap technique. So we know that pars plana vitrectomy with ILM peeling is a standard of care in large full thickness macular holes. OCT helps in surgical planning and prognosticating for anatomical and visual outcomes in full thickness macular holes. So correlation of OCT parameters and visual outcomes have been done in multiple studies. Now we are moving towards more functional outcomes in macular holes as compared to prior where anatomical closure was the primary expectation. So we also expected to see the ellipsoid zone restoration and external limiting membrane restoration and correlate them with the visual outcomes. So basically aim of the study to characterize the optical coherence tomography findings in large full thickness macular holes following ILM peeling with multi-layered inverted flap technique. So ours was a retrospective observational study. So we included 21 eyes. Surgical technique was pars plana vitrectomy with ILM and multi-layered inverted flap. We used gas tamponade, which was SF6 in majority of the eyes. Surgeon was a single surgeon. Platform was Ingenuity 3D heads-up digitally assisted surgery. The follow-up was minimum of 6 months. Imaging was done at 1, 3, and 6 months during the follow-up period. And imaging platform was Topcon Swepsos OCT. Preoperative parameters like minimum linear diameter, hole height, basal diameter, macular hole edges were assessed. And post-operatively, we see type of hole closure, appearance of subfoveal ellipsoid zone, external limiting membrane, retinal dimpling, and downfall were assessed. So preoperatively, majorly I want to highlight that the mean linear diameter of the holes was 667 plus or minus 154 microns. Majority of the holes were larger than 550 microns, and majority were more than 600. And mean BCVA was 1.33 plus or minus 0.41 logmar units. Post-operatively, the type of closure in about 92% of eyes showed type 1 closure, which is V or U, and about 9.52 showed type 2 type of closure. And at 6 months, the visual acuity BCVA achieved was 0.9 plus or minus 0.34 logmar units. And in about 8 eyes, that is 38% of eyes, we saw the restoration of subfoveal ellipsoid zone. So basically, as I said, in 90.48% of eyes, we saw type 1 closure, which is U or V shaped with the multi-layer technique. And eyes which achieved subfoveal ellipsoid zone restoration had a mean linear diameter of 610 plus or minus 101 microns. And subfoveal ellipsoid zone restoration corroborated with good BCVA with the minimum of 15 letter gain at 6 months following surgery. And there was no significant difference in BCVA achieved in eyes with or without downfill. And presence of retinal dimpling also did not change the final visual acuity at 6 months. ELM restoration was seen in all the eyes which had EZ restoration, which is logical explanation for that. So basically, the drawbacks of our study is we didn't have a comparative arm which compared it with standard ILM peeling technique. And studies have shown that ellipsoid zone restoration and ELM restoration takes longer time, more than 1 year. So we had a smaller, shorter follow-up period, that is 6 months. So we intend to extend the study for 1 year and just observe the OCT changes that occur. And a larger sample size would definitely help us in substantiating our clinical findings on OCT. Thank you.
In your study, all are large macular holes, no? You
Yes,
have been
all are
included.
large, and majority were more than 600 microns.
Many are doing temporal flap technique, no, nowadays? So
Yes, ma'am. The results are good with temporal macular holes. So this was basically done about 1 year ago. We are doing temporal flaps now. We are doing comparison of this multi-layered inverted flap with a temporal flap. And also we are trying to compare it with standard ILM peeling technique.
Okay. Okay, very good study. The next, thank you.
Thank you.
Next topic is oral epirelone for acute central serous chorioretinopathy by Dr. Tanmay. Yes.
Good afternoon. Psychological stress, type A personality, predominantly male gender, they presenting in their 20 to 50 years of age with central distortion of vision, micropsia, metamorphopsia, and reduced contrast sensitivity. Yes, I, Dr. Tanmaya, would like to present this effects of oral eplerenone on one of the most important differential diagnosis of the above mentioned symptoms, that is acute serous chorioretinopathy. So introducing to the topic, it's a chorioretinal disease which is characterized by serious detachment of the neurosensory retina and or the retinal pigment epithelium. It is usually a self-remitting course with reabsorption of fluid, and around 90 to 95% of the time, the visual acuity returns to normal. But some patients continue to have this blurring of vision even after the resorption of fluid. The pathogenesis is multifactorial, which includes choroidal vascular dysregulation. CSER has also been demonstrated with increased choroidal thickness. There are various studies which shows the involvement of mineralocorticoid receptors in the development of the CSER. So what are these? There is increased choroidal vasodilatation and leakage which has been noted following the activation of choroidal MR in rat animal models, and this phenomenon has shown to be inhibited by the use of NR antagonists. There are also many studies which has showed the effect of eplerenone in both chronic and acute CSER patients. Acute CSER usually does not require any treatment, but the persistent neurosensory detachment and its persistence for a longer duration of time can lead to irreversible changes in the level of photoreceptors and retinal pigment epithelium, leading to permanent visual disturbances and visual loss. Hence, we need a safe and an effective treatment for the faster recovery and resolution of subretinal fluid for optimum visual recovery. This is a prospective interventional studies wherein the patients who are diagnosed with first episode of acute CSER with a duration of less than 3 months have been included. Chronic CSER along with any choroidal neovascular membrane have been excluded. All the patients underwent visual acuity measurement, SDOCT at baseline, first month and second month and third month. Oral eplerenone 25 mg twice daily was started after physician's clearance till complete resolution of the SRF or up till 3 months. Renal parameters such as serum creatinine and serum electrolytes were constantly measured, and patients were monitored at baseline, first month and the third month. Results were tabulated in Excel and analyzed by SPSS software. So comprehending the results, 25 eyes of 24 patients were included with the gender being within 45 to 50 years of age, with gender preponderance of male in wherein it was seen in 66.66% of the individual, and the mean duration of symptoms lasted for about 15 days. We are comparing two parameters, visual acuity and the SRF values. Visual acuity was 612 and improving at more in 68% of the individuals at baseline, but at the first month it showed 84% of the improvement, and by the end of 3 months 92% showed improvement. 68 to 36 6 by 18 to 6 by 36 of visual acuity was present in 28% of the people at the baseline, and this significantly reduced to 16% by the end of a month, which shows that there was improvement in the visual acuity. 660 and less were present in 4% of the people at baseline, and none of them were present by the end of 1 month. SRF reduction was and about 92% of the people by the end of 3 months, and complete resolution was seen in 64% of the people at the end of 1 month and 92% of the people by the end of 3 months. Now comparing the SDOCT, which was taken at the baseline and after 1 month, there is in all these 5 patients there is significant improvement in the neurosensory. There is significant reduction in the subretinal fluid, which can be significantly noted after 1 month following the oral eplerenone therapy 25 mg. This is the comparative pictures which is taken at the baseline, first month and after 3 months. The A, B, C, D, these patients have shown significant improvement in the reduction of the subretinal fluid, but you can see that in the E1 and the E2 even patient, there is improvement in the pigment epithelial detachment also. The activity of mineralocorticoid receptor has been described in rats and humans in choroidopathy. According to Sunex et al., MR antagonist eplerenone has been shown to reduce SRF and improve the visual acuity in acute CSER patients. Like our study, Venkatesh R et al. Showed that there is complete resolution of SRF in 45, 55 and 65% of the people in the first, second and third month respectively. There is significant improvement in visual acuity up to 6.6, which was noted in 92 people of the patient, which was similarly told by Zuraki et al. Also. So oral eplerenone is safe and effective by achieving faster anatomical and functional outcome in acute CSER patients. These are my references. Thank you.
Yeah, very good presentation, Dr. Tanmay. My question is, you mentioned about the choroid thickness also, no? It's going to have an effect. What was the average reduction in the thickness measurement?
No, ma'am, we have not considered the choroidal thickness into the action, but we have compared only 2 parameters, ma'am, visual acuity and the subretinal fluid, based on the SDOCT pictures.
Yeah, I would have preferred to do that also.
Yes, ma'am.
Because the drug action and all what you were mentioning.
Yes, ma'am.
So we can compare that also as well. I
Yes,
think.
ma'am. Actually, we have taken 56 people into 56 eyes have been taken into consideration, but only 25 eyes have been reported. I mean, the analysis was done. But for the next 25, we would like to improve and more randomized control study could be adopted is what we prefer.
And also you have to compare the visual acuity improvement in the cases which are not given the eflarenon.
Yes, sir.
Because,
Yes.
because comparative study, because
Comparison.
3 months after any CSR can resolve most of it.
Yes, sir.
In our clinical
Yeah,
experience.
that was the main topic, criteria, sir. Within 3 to 4 months, the acute CSCR episode will anyway come down. But the longer we prolong, the neurosensory detachment will cause disruption in the photoreceptor layer. So there will be permanent visual loss.
So you started the treatment around and what point of time? 3 months time? Before 3 months?
No, sir. Immediately when we when the
patient.
patient came, when we diagnosed on the
Because you have to have a control arm of not treating these patients.
yes, sir.
And comparing the two
Yes, sir, yes.
outcome. But the studies internationally, I've just gone through the American Academy
Yes.
literature. They're saying that eplerenone has been found to be not useful. Previously there were anecdotal reports of success with that.
Yes, sir.
But presently, now it has been stopped, not being suggested.
Sure.
What is your opinion on that?
There are very majority of. There are studies which show that there is improvement, like this study and many other studies at Zuaki et al. And all. They have shown
Basically, judges are of the opinion that as CSR is a self-limiting disease, to establish the fact that eplerenone is better than observation, you should have a control arm
Yes, sir.
telling that this arm is doing better than the non-interventional arm.
Sure.
That's it.
Basically,
And also then you should also compare the visual acuity status and other parameters of vision
Yes.
between the two arms, whether the use of eplerenone is anyway superior as far as the visual function is concerned between the two groups.
Maybe the more
With or
contrast.
without.
Sure, sir.
basically eplerenone can be used only in case of chronic CSR, that is non-resistant to any therapy. You
Yes,
have to
sir.
use.
Actually, more studies are present when in chronic CSCR. In acute CSCR, it is very less number of studies have been made. Thank you.
Yeah.
Thank you.
Thank you, sir.
We
The
are going
neg-
to the
yeah.
last presentation. Video audits are better than case sheet reviews for surgical procedure related data. Vidhata V.
Vidata.
Is he there? No.
The previous papers, anyone?
Anyone who was absent, like you can.
Free paper
Dr.
410.
Chetan Desai, Dr.
Dr.
Sunil
Ganekar.
Ganekal, and Dr.
Mohammed
Muhammad Nisal KS. Anybody is present? No. So with this we are concluding this session. You can have a photograph with the speakers.
The
Rest we
speakers,
can
they
put
are
others.
informed.